Welcome to MedLive. Today's program is Age-Related Macular Degeneration, or AMD, risk reduction and improved treatment outcomes for diagnosed people and those at risk. My name is Matthew Levine. I'm the Grants Advocacy and Partnerships Director at the American Macular Degeneration Foundation. I'm joined today by Dr. David Brown, Director of Research at Retina Consultants of Texas, Dr. Pamela Brown, Director and President of the Professional Eye Care Center in Niles, Illinois, and Eric Ringham, who had a career in journalism in Minnesota, and he's going to be speaking about his experiences as a sighted helper. This program is presented in collaboration with the American Macular Degeneration Foundation with support provided by Novartis Pharmaceuticals Corporation. Now, part of what will make today's program of greater value to you is your participation. We'd like to hear from you during this program, so please take a moment to ask your questions. Just type them into the box below at any time during this discussion. If we can't get to your question during the program, we'll find a way to follow up with you. Please keep in mind that the question should be general in nature. We're unable to answer questions about your specific case, but we encourage you to bring those questions to your doctor. In fact, one of the issues we're going to be addressing today is how important it can be for you to develop constructive communications with your eye doctor. For your reference, the presentation slides are going to be available for download in the event resources section of the player, which is located, again, under the video box, where you can see me and the other panelists speaking. Here are our disclosures, if you care to see them. In today's program, we're going to be talking about the basics of macular degeneration, about tests and early detection, about treatment options, and about managing your condition. So let's get right to it. First, we're going to be talking about the basics of macular degeneration. And as promised, we want to get you involved. So here's a quick survey. If you will click on your responses, we want to know what you want to learn about macular degeneration. A, how do I know if I have macular degeneration? B, what are my options for treatment? C, what can I do to manage my own condition? D, any other issue that you would like us to raise, and we'll see if we can get to it. So it takes a few seconds for us to put together your answers. And while we're waiting, let's start with a quick question to Dr. Brown. What causes, Dr. Brown, what causes macular degeneration?
That's a great question, Matthew. You know, the retina and the layer behind it's an amazing structure. It provides all our input and everything we see. And it's actually the most metabolically active part of the body. It uses up 14% of the body's metabolism, and it's way less than 1% of you. So it makes sense that this very hardworking tissue, just like the belts in your car or the tires, would be the first thing to wear out. Mm-hmm. And macular degeneration is basically a premature wearing out of this incredibly active structure. Certainly there are things that predispose you to that, mainly genetics, Northern Europeans that kind of look like you and I, genetics and things you can do to your body, how you take care of your diet and lifestyle, smoking, et cetera, can accelerate all these aging processes.
Okay. Thank you very much for that. And as you were speaking, we got an answer to our poll, which is C. A lot of people want to know what they can do to manage their condition, and we promise you that we're going to be getting to that extensively. Let's turn it over to Dr. Lowe.
Yeah, absolutely. So good to be here with everyone today. So great explanation by Dr. Brown on really what macular degeneration is, but let's look a little bit at the mechanics behind it. So if you think of your eye and the optical system like a camera, because a camera was invented off the optics of the eye. So like a camera, you have a lens that light enters and then it hits the film of the camera to take and capture an image. Well, your retina is that film in the camera. It's the part of your eye that takes all the light energy up to the brain so that we can perceive our world. Macular degeneration, due to mostly aging, is a chronic condition that slowly robs us of the central vision. And that's what it mainly affects. And as you can see in the image on the slide here, this would be someone looking at a family sitting in the park, and it's hard to make out faces, especially right in the center of the vision. Right in the center of our macula, we have the highest concentration of cone or color receptors that give us a very good contrast vision. So not only can we lose central vision, and you see a large area of central vision loss here, but you can also have dead zones. So you may see fine in the very center of your vision, but you could have little areas off center that start not transferring the light to where it needs to be. So there's subtle changes. Don't just think all of a sudden I'll see this kind of large central defect. Little things can be happening slowly. So if we look at the risk factors, what are we at risk for? Some of these risk factors we can control, some we can't. And as Dr. Brown said, the ones we can't are time going by. So age is definitely a risk factor, and our family history, our genetics. Right? Are we Northern European? Women tend to, on average, live longer and get macular degeneration at a little bit higher rate. There are other things we can control, though. We can actually control what we put in our body and how we move our body. And so as you can see here, some of the risk factors are nutrient-based. If we have a high-fat diet, if we're taking in a lot of sugar or drinking a lot of alcohol, those are things that age our cells and cause inflammation. And when it comes to macular degeneration, that inflammation is right in the center of our vision. Certainly, their studies have shown if you have a lot of sun exposure over time, that can be a risk factor. And also, if you're overweight, that's hard for us to absorb the nutrients in our food. So I'd like Eric to jump in and just give his take on this.
Yeah, I hardly ever win anything, but here I am. I've got old age going against me. I've got family history. My dad had macular degeneration the last half a dozen years of his life. I used to be a smoker. I used to have high blood pressure, and I was fairly, some people said I was obese. Okay. And it occurs to me now that it's terribly hard to quit smoking when you've just lived all your life with the idea that this may cause lung cancer. And you just kind of get used to that risk. But boy, if somebody had told me that I was putting my vision at risk, I think that might have helped me quit earlier. I never heard that.
Yeah, absolutely. And thank you for mentioning that smoking, because that increases the risk up to 5 times of vision loss from macular degeneration. And that's certainly a modifiable risk factor. Those with high blood pressure and high cholesterol are at risk for cardiovascular disease. So that can contribute to risk also. And then we also can, have issues with some medicines that we take. And that's really more related to if you convert to the wet form of macular degeneration. So with any condition, let's look at the different stages of macular degeneration. There's an early, intermediate, and then an advanced stage. And of course, being a primary care optometrist, I'm all about that early stage. And so we're going to talk about ways we can, in eye exams, pick up very subtle symptoms that you may be having in your vision that sometimes we just put off. Well, I have cataracts, I'm getting a little older, but really in that early stage is key. And so we'll talk about some tests that are great at picking it up as early as possible, because we know if we can catch any disease early, we can intervene at a greater, we can reduce the chance of going on to the intermediate stage, which that's where patients usually start noticing it. And then again, vision loss has already taken place. Or then obviously we want to avoid the advanced stage. So I'll have Dr. Brown talk about the structure changes.
Sure. I have patients come in all the time, even patients that are undergoing therapy, and their friends are asking, they want to know, do I have dry or wet? And it's an excellent question, but actually everyone starts with dry. Dry is what is that premature wearing out changes. The first changes we see are bumps on the back of the eye that are the garbage the retina makes, called drusen. I tell patients, kind of like aging spots on your skin, I expect some, but in macular degeneration, you have way too many. And that's because that really critical retinal pigment epithelium, the RPE, is wearing out too soon. In and of itself, the dry macular degeneration hurts your dark adaptation, a little tougher to see when you drive at night, et cetera, but most people do okay visually, unless they get one of two complications. Either new blood vessels grow through the back wall of the eye, kind of like weeds go through the cracks in concrete. That's called wet macular degeneration because you get bleeding and fluid, and it causes the scarring down and blindness centrally pretty quickly over a few months without treatment. The other complication is more insidious. It's called geographic atrophy, and what that is specifically is that RPE wears out like carpet, where it gets thinner and thinner, and finally you get a patch where it's missing. And the retina over it can't function without it. So that's where patients look out. And parts of their vision they can see, but they'll be missing multiple letters here or even a whole word. When that's off to the side, you don't notice it as much. It goes very, very slow, but once it gets to the center, boom, you can't read. And to the patient, they seem like it's very quickly. Early diagnosis, as in anything, is the best way to catch something. It is amazing. We generally catch the first eye relatively late in the game. The brain is really good at ignoring one-eyed problems. And so we often have a patient come in with pretty advanced disease. They were getting by fine because they're getting by with their other eye. But certainly regular eye exams with your primary care optometrist or ophthalmologist, monitoring, kind of covering one eye if you're at risk and know that you have dry AMD. It's a great idea to use either an Amsler grid, a checkerboard grid, or Venetian blinds, or really just check each eye. Because the sooner you get active therapy for wet macular degeneration, the much greater chance you have of regaining most of that loss and maintaining your lifestyle. Obviously, the biggest thing I see, and maybe this is a guy thing, it's more of a guy thing than a lady patient thing, but denial. You know, I see patients that, you know, are really in denial until they wreck their car or, you know, there's something that, you know, it's not just a smudge on their glasses. And so don't be in denial. If you know you have a family history of macular degeneration, if you've been diagnosed with early macular degeneration, check each eye, check in with your doctor, and any hesitancy to see and check it out, you're better off catching things early. Matthew, I'm going to let you take it from here.
Okay, now we're going to watch a clip of Sandy, someone who has macular degeneration, talking about her experience at diagnosis.
I noticed a change. I was seeing darker out of my right eye. And so I made an appointment with an ophthalmologist clinic that I had gone to. And they examined me. A young doctor examined me and said, and this was about 5 months before spring of 2005. And he told me that I had the beginnings of a cataract. And that's why I was seeing darker. And to just go on, carry on with my life. And if I saw darker, if it got any worse, then I should come back in about 6 months. Well, it did get worse. And I was really seeing darker. So I made another appointment with the same clinic about 4 or 5 months later. At that time, I was seen by an older doctor, ophthalmologist, who we had waited all morning with your eyes dilated, and he examined me. And he immediately says, you're going to have to, I've made an appointment with you at a retina specialist's office. You're going to have to see a specialist. And I said, why? And he just said, well, you're just going to have to go. And I said, well, fine, make it on another day, because I've spent all morning waiting to see you. He says, no, your appointment is this afternoon at 1 o'clock. Please be there. And he wouldn't tell me why. So we went on that day and to the retina specialist's office, the same retina specialist I'm seeing to this day. And by the end we were in his office at 1 o'clock, and the doctor had told me I was going to be getting a shot if I wanted to save my vision. And I thought to myself, well, no big deal. I've gotten shots in my rear end all the time. He says, no, this shot's going to go in your eye. And I says, oh, I want my husband in the room. And so my husband was in there and watched me get my first shot in October of 2005. He diagnosed me with wet macular degeneration. My vision is darker in both eyes, sees darker than my husband's. He does not have macular degeneration. He has very good vision. And my left eye, especially the one with geographic atrophy, sees a whole lot darker than my right eye, which also has obviously the macular degeneration. Even though it sees 20/20, that's a good light. But I see darker out of both eyes. And I don't know how much darker than normal.
To me, when I see that clip, I'm struck by how quickly someone can go from being undiagnosed to being diagnosed with macular degeneration to being a patient receiving an eye injection, literally in a matter of hours. I'm sure a lot of you watching today can probably relate to that scenario. So within what Sandy told us, a few things emerge that we hear from people with macular degeneration really quite frequently when they contact the foundation. Not only how quickly the diagnosis occurred, but how little information the eye doctors seem to give them at that critical time. I'm just wondering quickly, would either or both of you doctors like to comment on, how that can happen, should it be happening, or why that's a common experience?
Yeah, Matthew, great point. And one reason I've seen over the years that's unfortunately a common experience is because patients always think if something's important, the doctor's going to say something, and doctors always think if something's important to the patient, they'll say something. So there can definitely be this miscommunication and this disconnect. So open communication, pushing for the answers to what's really concerning you is so key.
Let's talk a little bit more about what you just raised, and that's the importance of communication and kind of when that gets established. So back in 2018, we at the foundation did a survey of people with macular degeneration to find out what their experience was like at diagnosis. As you could see, almost 1,000 people responded, and we discovered quite a few things from that survey. One, most of the people were diagnosed during a routine eye exam. You could see 61%. What does that tell us? It tells us it came as a surprise. Also, even if people had seen some changes in their vision, they requested an appointment with their doctor, they went to the doctor, and they received the diagnosis of macular degeneration, you can imagine that that diagnosis might have come to a surprise to a number of them too, just the way it had with Sandy in the video we just saw. Why is this important? Because at the very moment when someone has to take in and comprehend really important information about their health and their life, they're kind of in a state of surprise, maybe even a state of shock. So as we'll see, that element of shock or surprise really has an impact on the establishment of a relationship. We asked if people at diagnosis felt comfortable asking questions. Now, good news is 3 out of 4 did, but 1 out of 4 didn't. 1 out of 4 people with macular degeneration is actually a huge number, considering that there are about 11 million people with macular degeneration in this country right now. So 1 out of 4 people are uncomfortable. Why? We asked why. We found out, as we described before, that about 3/4 of them were simply overwhelmed, probably overwhelmed with emotion. But a significant number of people also felt that they were just being rushed. It was their perception they were being rushed. Whether they were being rushed or not is a separate issue, but they felt rushed. And they also felt that the doctor just didn't have time to answer their questions. Now, I'm sure there are a lot of other reasons behind those, but when you take those issues all together, what you have is a significant number of people not asking questions at a critical time. And also, you can see that it's a barrier to establishing right from the get-go communications with your doctor. There's a lot of fear involved there. I also want you to quickly just take note that about 250 people responded in our earlier question. 1/4 of the 967, they said they were uncomfortable. But when we asked more questions about feeling comfortable or uncomfortable, 470 people answered. That kind of tells you that it's much more prevalent to feel uncomfortable asking questions than, than might be apparent at first. We also asked another very important question. When you go to your eye care specialist, are you accompanied by someone who acts as your advocate and can take information or ask questions if you're too stressed at the time? Answer, 3 out of 4 people do not go accompanied by somebody. And once again, this is an incredibly important issue because it's a missed opportunity to get information or express yourself. I'm wondering, Eric, if you could talk about that experience.
Oh, sure. It's with my dad. I never took him to the doctor because he had a wife at the time, my stepmother, but I do go with my wife. I'm currently married to a woman, Anne Wagner, who suffers from retinitis pigmentosa, and she's profoundly blind from that condition. So I go with her to first of all, to her eye specialist appointments. Yes, that was the first appointment that she took me to, but that has now grown into me going to just about every appointment with her. And I don't see how blind people manage to keep track of things. As a sighted helper along, I don't like the term caregiver for reasons that could take me a while to explain, but I go along with Anne not because I'm taking care of her, but because I'm a helper. I'm good at things that she's not good at. I can keep track of information on it. I can take notes. I can listen carefully and remind her of things that she meant to bring up. But also just the business of going into a doctor's office. Sometimes we go from the waiting room, a nurse will say, "Okay, follow me," and doesn't stop to say, "Would you like me to give you an arm to hold on to?" So there's a lot about just a blind person's ability to navigate the world that I think it really helps to have a companion, and in a doctor's office. If it's somebody you're married to, all the better, because some of those exams, as you can imagine, can be pretty intimate.
Well, thank you for that insight. I think that's going to help a lot of people start to think about how they might ask people to go with them and what they can describe their role as being. So we're going to take another little poll of the audience now, just to get a sense of what your main concerns about macular degeneration are. So again, click to choose your answers. And the questions are: A, that I will lose my job or my relevance in society; B, that my children could be at risk; C, that my macular degeneration will get worse; or D, that the treatments are going to involve injections into my eye. So please take a moment to answer the questions. And while we're waiting, another quick question for Eric. As a caregiver, is there anything that you wish you had known when your significant other was diagnosed?
A lot of the basic skills about helping blind people get around and navigate the world, those can be learned probably in a day. How to offer your arm, and how to step off a curb and onto a curb, and how to lead somebody, how to sort of signal with your body that you're going to be going through a narrow space. Those are all things that are immensely helpful, but don't come perfectly naturally. I had to have them explained to me. My dad explained them to me, and then I met Anne, and it was sort of a cool thing to be able to show her from our first meeting that I knew a few of the etiquette questions. Blind people hate it if you reach out and grab their arm. They'd rather offer it to you. So the things that I wish I had known before are really just pretty. They mostly have to go to the psychology, to the questions of how to be supportive without getting in the way. That is, if Anne should ask Siri or Alexa, there she is, what time it is, I know now to keep my mouth shut because, I know that she's asking on her own and doesn't need me to jump in, even though I know the time and could tell her more quickly than the artificial intelligence could. It's important for people to do the things that they can do themselves. Know when to keep your mouth shut.
All right, so you're bringing up a really interesting point, which we'll get to, which is being proactive. But quickly, just for everybody's information, most of you in response to the questionnaire said C. Your concern is that your macular degeneration will get worse. And we're going to get to that very quickly too. Let me just get back to this issue of being proactive about your macular degeneration and the kind of questions you might want to formulate or bring with you when you're with your eye doctor. And most of these are in anticipation of possibly developing macular degeneration. What are my risks? If I'm at risk, what can I do to reduce that risk? What kind of tests do you recommend I get and maybe when? How often do I need to get checked? And should I see an eye specialist? And you're going to start to think about these questions if you have a history in your family of macular degeneration, as has been discussed. So getting back to this issue of fear of macular degeneration progressing, as you've heard already, getting diagnosed early is really key to the whole situation. So we are going now to move ahead and talk about tests for early diagnosis. Again, we'll start with a quick poll. What are your barriers to being tested? A, I'm afraid it will be painful. B, I'm afraid nothing can be done at this point. C, I'm afraid of the diagnosis of finding out that you have macular degeneration. D, I'm not aware of any testing for macular degeneration.
In my case, I know, excuse me, Matthew, I know that I'm at risk because my father had macular degeneration, and I get my eyes examined once a year, and I always ask them to look, and they say, no signs of it. Should I be doing something else? I mean, does that mean that my answer is D, I'm not aware of testing for AMD?
Well, let's ask Dr. Lowe to answer that.
Yeah, great point. We said this is a disease related to age, and we know once we get into our 40s and 50s and 60s, other things are happening to our eyes, cataracts being the main one. So our vision naturally does start fading with time. So it's really determining, is this truly a change in my retina where my macula is degenerating, or is it the normal aging process? And that's what is key to being in tune to any changes you may feel you're having in your vision. And to Dr. Brown's point, it's going to, diseases of the eye are asymmetrical. They don't both happen in the eyes at the same time. So it's really, really important to kind of cover each eye. And we'll talk in a moment about having the comprehensive eye exam. But as a caregiver, it's equally as important to notice changes in your loved one's perception. Sometimes you may be going from like the lobby of a movie theater into the theater, and we all know it's darker and we have to kind of manage. But if you notice you're grabbing that rail more, you notice your loved one is really struggling when they walk into a dark room, way different than they used to, and their navigation is off, that can be one of the early signs.
Thank you, Dr. Lowe. As you were speaking, our answers came in, and it sort of bears on the conversation. There's a split in our answers from the audience. B, I'm afraid nothing could be done at this point. And D, I'm not aware of testing for macular degeneration. So Dr. Lowe, if you could just, pick it up and keep on going, I think you're going to get to some of those answers.
Absolutely. So again, once we get in our 40s, there are natural aging changes to the eyes. One is called presbyopia. We just can't read like we used to. We may see well far away, and then all of a sudden our focusing goes down. So that's why it's so important to see your primary care optometrist or ophthalmologist once we're in those high-risk age groups every year, whether you're having symptoms or not, because symptoms can be very subtle. And what we equate with going to the eye doctor is, well, it's just, can I read the chart or not? Man, I could do that at home, cover one eye and the other and see if I could read the chart. But early stages of macular degeneration, those subtle changes are what we pick up. So we not only have you read the chart, the high contrast chart, white, bright light with a big dark black letter, we also test what's called contrast sensitivity. We have special charts that start changing the contrast. If the background's a little grayer or dimmer, are you reading as well? Because again, that could be the first sign of early macular degeneration. And as Dr. Brown stated, you could see here in the image, there's an Amsler grid. It's simply having you stare at a center target dot, and do you start noting subtle distortions that you may not pick up when you're reading. And what's really great is that we'll talk about in a moment, there's a great new test that I would not practice without now called dark adaptation, because that could pick it up years before I see it as your doctor or you have signs of vision loss as any symptoms. So we, obviously we always look into the eye, we dilate you, we take a look at the surface, but the other tests we do, let Dr. Brown and I see what we can't see below the surface. And so one of the main technologies is called OCT, or optical coherence tomography. It's a very easy test. Patients are dilated. It only takes about 15 minutes from start to finish. It's just an infrared light, which you don't feel. You just look at a target and boom, boom, boom. It takes sections of your retina and gives us a really good three-dimensional view of what's going on, not only on the surface, but below the surface. Then if you're at risk for dry converting to wet, we run a test called fundus fluorescein angiography. Now that requires dilation as well, takes a little bit longer, and that's a little bit more invasive because there's a dye that's actually easily injected into a vein, and then again, just high-speed photographs taken so that we could see, is anything starting to brew below the retinal pigmented epithelial layer, and are there new blood vessels that are starting to grow and get leaky? But this is what's been a game changer, because good science has told us with dark adaptation testing, we can pick up if you are starting the macular degeneration train. If you're on that train and it's starting to leave the station, we can pick it up with this very easy medically billable test that measures how you go from light to dark. So when we go to the eye doctor, there's some numbers we know, am I 20/20, am I 20/30? What were my eye pressures, 14, 15, 16? Well, with dark adaptation, we have a new measurement we take, and it's called your rod intercept time, or RI for short. And anyone who can adapt from light to dark within 6.5 minutes or less, we know that whether there's structure or function changes or not, that you're good. Your retina is not getting sick yet, and we don't have to worry about macular degeneration impending in the near future. So this has been a really big game changer in our practice. Anyone who comes into our office now, we always ask the simple question: have you had a change when you're in a darker situation? We used to say driving at night, but a lot of times patients will be reticent about talking about driving at night because they think, as doctors, if we say they have a problem, we're going to take their driver's license away. But really, it's any dark situation. If you're noticing that, this test really helps distinguish.
Okay. Well, thank you very much. We're going to move ahead a little bit now, and we want to start getting into our next section, treatment options. Well, actually, I'm sorry. We want to hear from Sandy again, our patient. So we'll see from.
My eyes do not adapt to changing lights very quickly at all. Very, very slowly. From the computer screen to walking in the other room, I'm a blur until my eyes adjust to that light. From when I walk out of a bright building to the outside, my husband can see where he's going. I can't, it's pitch black until my eyes start adjusting. And even then, my eyes outside at night, after getting my new cataracts, lenses put in, do not see very well at all. I have halos around all the lights, so there's still a problem. But I'm not out much driving at night anyway. So my first concern was I going to go blind? And that evening, the same evening, after I got the shot in my eye, I came home, and that very night I started Googling macular degeneration. And immediately I saw that I would never go blind, and that I would only lose my peripheral vision. Only lose my central vision and always retain my peripheral vision with macular degeneration. That was really, really comforting to me. So knowing that I would never go blind, that was obviously what was most concerning to me, was I going to go blind?
Dr. Brown, just quickly as we transition into the next section on treatment options, could you just briefly address that fear, which I'm sure is a very common one, will I go blind?
Yeah, so macular degeneration really takes over an incredibly important part of your vision, the center where you recognize faces and can drive and read newspapers. But it is very rare to lose that ability to find a doorway or to ambulate. And so unlike, the difference between Eric's dad and his wife, she has difficulty, going off a curb. Most macular degeneration patients have less trouble with that and more trouble, recognizing their grandkid when they come in, which can be very emotionally distressing, but just a different kind of blindness. Total darkness, needing a guide dog, macular degeneration almost never happens.
Thank you for that. Let's move ahead now into our third section, treatment options. And again, we're going to ask to hear from the audience. So click your responses. I'm going to read out to you the questions. What are your barriers to treatment? A, not having the time. B, not having a car or transportation. That's a very real issue for some people. C, not having the money. D, you're afraid of the injections. Or E, despair. Despair is an undiscussed issue, but it leads to inactivity. So please make your selections. And as you're doing that, let's just ask Dr. Brown, how come you have to receive these injections into your eye?
So I run the largest research center for macular degeneration and diabetic retinopathy in the country. And we've literally tried 18,000 different mousetraps, pills, drops, systemic drugs. It's actually one of the biggest things is that a lot of the drugs we use go to the exact mechanism, but it's way safer just to stop that mechanism in the eye as opposed to your entire body. The systemic drugs we have, in other words, into your body like IV or a shot, a lot of them worked, but caused, liver problems or kidney problems, or, you take an elderly patient and you give them some other health problem. It's actually way safer to go straight to the eye. We are looking for longer ways of doing it, potentially eye drops and such. We've been trying for 15, 20 years, though. We'll figure it out. So.
Okay. Thank you. And the answer has come in. Barrier to treatment, most people are afraid of the injections. Okay, so let's move ahead with the presentation, Dr. Brown.
Yeah, so basically treatment options, when I started research on this and started treatment, we didn't have any options other than laser, which killed your center vision quickly to make it where the blind spot was smaller. In other words, you could, you lost the size of a grapefruit instead of waiting it to the loss of a basketball. Starting in, the initial trials, 2001, 2002, we suddenly had treatments that not only could you prevent further vision loss, but the average patient improved vision from presentation. And what I mean by that is they actually saw better on the eye chart, and that was maintained. Some people ask, when's there going to be a cure for macular degeneration? Essentially, that was the cure for macular degeneration, but it's kind of like the cure for diabetes is insulin injections. It requires ongoing treatment. The treatments we have are specific. They block growth factors that cause those new blood vessels or weeds to continue to leak. And so this is a treatment for the wet macular degeneration, does nothing for the dry. And the drugs don't last forever. And so that's why most patients have to have ongoing injections. If you catch the disease before there's scarring, before there's bleeding under the retina, you can get a lot of recovery. In other words, recovery back to driving vision, et cetera. I mean, certainly not, you can't promise that to everybody, but if you catch people in time, we improve most people to where they're able to still live at home and take care of themselves, even in their only eye. So the more you understand your treatment and you become active in it, the better your outcome. And so doctors mean well for their patients, but a lot of doctors have what's called transference, where they kind of push their feelings off onto the patient. And they feel that the patient, it's a burden for them to come, and they try to push the patients to get as few treatments as possible. And I agree with that. You want to treat as little as you can to maintain no disease activity. However, if you go over that line and you have recurring disease activity, over time you lose disease. And so especially if you are getting successful treatment, which is the majority of patients, tell your doctor, I want to get as much treatment as it takes to keep me at home so I don't have to go to a care facility, so I can maintain my independence. And that helpful action and discussion with your doctor can help you. So dry macular degeneration is to fix that sort of the fountain of youth, right? I've already told you it's an accelerated aging process. And Dr. Lowe has discussed some, certainly healthier eating, green leafy vegetables, all that stuff's good. Maintaining regular exercise. The choroid, or the layer behind the retina, is an amazing vascular area. Certainly if your heart doesn't work, if your blood pressure is high, all of that stuff decreases choroidal blood flow. What you can do to stay healthy, what your mom or grandma told you to do all your life is probably good advice, even as you get to be their age. So I was the principal investigator for this part of the world for the AREDS studies. And we've shown with the AREDS II study that this combination of antioxidants slows the progression of dry macular degeneration. And let me step back. So a lot of doctors are skeptic about vitamins and such. And we actually designed this trial, or the people that designed it, Rick Ferris and others, we designed the trial to prove that vitamins wouldn't work, because there's all this anecdotal evidence and it didn't seem like there was any great evidence. So we designed these trials, and sure enough, we were wrong, and physicians are often wrong. But taking this particular vitamin decreased the incidence of advanced macular degeneration, which is what those two things I'm talking about, the geographic atrophy and the wet, by 25%. So it's certainly worth doing. The only comment I have on this particular formulation is that the lutein dose that was chosen, 10 milligrams, at the time, the argument was that was probably too low. But we chose that because it was really expensive at the time. And what the National Eye Institute didn't want to do was to recommend a vitamin that the average person couldn't afford. And so there is great data to show that lutein is incredibly safe. I don't have strong data to show that more lutein is better for you, but if you want any extra credit on top of AREDS II, I have patients take extra lutein. It's now way cheaper, 20 to 40 of lutein. It usually comes with zeaxanthine and another carotenoid. You're never going to hurt yourself with that. And the most important thing I can tell you, to tell your grandkids and your kids, I've told you it's genetic. There's at least 30 genes that you're passing on to your kids and grandkids. Stopping smoking now decreases your chance of having more trouble in the fellow eye. But even more than that, having your kids or grandkids not smoke is probably the number one thing you can pass on to them to help them from getting into the shape you are with macular degeneration, especially if you were a smoker. Let's talk about the treatments. So anti-VEGF therapy is blocking a specific target that your eye makes. And it blocks it in a way that turns off the signals that's making those blood vessels grow and leak. And it says the goal of anti-VEGF therapy is to preserve, not improve vision. But I sort of disagree with that. I think most patients, if I catch them early, I can improve their vision. And if I treat them frequently enough, then I can maintain that vision. And so it is a shot in the eye. It's an incredibly tiny needle. We use a 32 to 33 gauge needle, which is way smaller than an insulin needle for your diabetics. It takes literally, you got some numbing drops and ins and outs, but the actual portion of the procedure that I do is, not very long at all, less than a minute. Critical parts, betadine and antiseptic around the eye, because the chance of hurting you with an injection is literally 1 in 6,000 or 1 in 7,000, that chance of an infection. And everything we can do to mitigate that by betadine, cleaning your eye and all that, certainly we want to decrease all those. At the time, when we started the research, there were no drugs that are effective. Now there are 3 FDA-approved medications and 1 off-label, bevacizumab, which is Avastin. The first drug, ranibizumab, which is Lucentis, aflibercept, which is Eylea, and brolucizumab, which is Beovu. And each is kind of like antibiotics get better. Each has its own sort of strengths that increase duration. And I want to go over this, because patients get really, and marketers, et cetera, get really fixated on, oh, this is a 12-week drug or this is a 10-week drug. And it turns out that just like your swim team, it's a bell curve. There are fast swimmers and slow swimmers. And there are a lot of patients that even the best drug can only go 5 or 6 weeks. And there's other patients where all the drugs can go 10 or 12 weeks. And so your treatment has to be tailored by your doctor. If you clear drug fast, in other words, if I put the drug on your eye and you don't know it, but you're clear drug fast, it turns out if you clear one drug fast, you clear them all fast. And so you can't, patients go in and they are getting treatment very frequently because they need it. And they hear that, oh, there's a 12-week or a 16-week drug. That is true on average, but they're not an average patient. And that's what fills up my waiting room, because the patients that need the most injections are obviously there more frequently than the others. So it is a tailored treatment. It's not one size fits all, but these are amazing therapies that prevent millions of patients from having to go into nursing homes, keep millions of patients continuing to drive, continuing to see their grandkids, et cetera. And we have ways to mitigate the side effects, mainly the infection. But the most important thing I can tell you is missed doses result in vision loss. Sometimes you get lucky, but you want to, when you have to miss, you have to miss. But certainly you want to try to figure out a way. One of the things I hear the most from my patients is they're not concerned about the injection. Once they've had several, they know, hey, this is nothing. They're not concerned about side effects because they've had multiple injections. But the biggest concern they voiced to me is, I'm being a burden to my caregiver, my helper, who's having to take off from school and get a substitute teacher or help them. And I think that's one of the best things you can do with a diagnosis of macular degeneration is sort of a family powwow. How can we pool resources so that, that help is passed around, and that the patient with macular degeneration doesn't get vision loss because they're afraid to ask somebody to take them to their doctor's appointment or for their care. So again, some patients get a lot more treatments more frequently than others, and that's really luck of the draw and tailored by your doctor. And so you'll want to make sure that you can do that and work with your doctor. Also, if you're in a safe area and you want to learn how to use Uber Health, there are great options out there for rides. Some patients are older and that's not a great option, but some patients it's a great option. Lastly, as I told you, I run a big research center. We've got a bunch of cool things out there. We have some drugs right now in phase 2, phase 3 that look like they could last the average patient, up to 6 months. We have a port delivery system, which is about a 10-minute surgical procedure where I put a sustained release device under your eyelid. And it's refilled with the same drugs that I give you in the eye, but it can last 6 months out to 15 months. There are combination drugs that block more than VEGF, and kind of like combination antibiotics, we think we can get better efficacy. And then we got some moonshots. I am in Houston. I am the retina doctor for NASA for all the long-term space flight. And so I do believe in moonshots because I take care of astronauts every day. But that's also one of the reasons why we work on things like gene therapy. We have multiple phase 2, phase 3 gene therapy trials now, where if we can figure it out, it basically infects your eye with a stable virus that then makes the same drug I'm injecting. In other words, makes your eye a factory for more drug. Eye drops, we've tried a million. We don't really have one. Maybe we'll figure it out. Oral tablets have worked, but they've had systemic side effects. There's also hope for that. And lastly, stem cells, which I hear about every day. You know, stem cells make a lot of sense, but macular degeneration is one of the hardest therapies for stem cells because you truly have the interaction of some of the most complex cells in the human body that all have to be hooked together precisely in a sequence. And when the RPE dies, the photoreceptors die, the Mueller cells die. And by the time you really need, by the time we do stem cell therapies, it's too far. It's probably too far gone in the system. We probably need to do that earlier. We are working on it with multiple investigators around the country, but stay tuned. That's not ready for prime time yet.
Thank you, Dr. Brown. That was really quite thorough. And, you know, as immersed as I am in the category, I learned some stuff from you just now. Let's go back to some of the issues that we discussed a little bit earlier, which is your encounter with your eye specialist and what you take away from that. So going back to the same survey we were discussing before, we wanted to know what patients were told and how they reacted to that. So we asked, after an eye specialist consultation, do you feel empowered to treat your macular degeneration? If you look at this slide, it's almost a 50-50. A lot of people said no. And, you know, what we're discussing largely today is giving you the most information we can so that you can be empowered to ask the right questions. And so we're hoping you don't have the same kind of experience as those that took this survey. We'll see. Again, we asked, did you wind up having questions about your treatment that you did not ask? 37% said yes, they hadn't asked the questions about their treatment. Now, Dr. Brown just gave us a great summary, so you're probably going to be well equipped. But if you have questions, you need to ask those questions. Again, we asked, were these nutritional changes suggested as part of your treatment plan? This is if you were diagnosed with dry macular degeneration or early dry macular degeneration. This, again, is almost a 50-50 split where patients were simply not told that there were nutritional options available to them, whether it's eating whole foods and adopting a new kind of way of eating or taking the nutritional supplements that Dr. Brown referred to as the AREDS II formula before. So patients that we surveyed not too long ago were not getting necessarily adequate information. If you go down the list of risk factors that are modifiable, that you're in control of, look at the answers to this question. Were lifestyle changes such as exercising or losing weight suggested as part of your treatment plan? Almost 85% of the time, the response was no. So patients need to be told this, and it's really, the onus is on both sides of the aisle. Patients need to ask about the things they can do, and physicians probably need to do a little bit better job of communicating these. It's not the same with all physicians, but it is a common experience, as you can see from the nearly 1,000 people who, answered our survey. The kind of questions you might want to ask right from the get-go, or do I have wet or dry macular degeneration? You really want to find out what stage it is in, early, intermediate, or advanced. Can diet or nutrition therapy slow the progression? And which anti-VEGF treatment do you suggest and why? That's a discussion. I mean, Dr. Brown just covered the several different kinds of anti-VEGF drugs that are out there. They all have slightly different efficacy in different people. And you have to work with your doctor. Your doctor is going to suggest the one that's best for you. That's without a doubt. but you should understand why it's best for you. So, also understanding what stage of your disease you're in gives you a sense of how much there is that you can do. So, getting involved in your own care is really the name of the game. And I think we're going to start to really, talk about that as we talk about managing my condition, which is the next section that we're going to move into. All right, so let's start off once again with a quick poll. What are your long-term goals for managing macular degeneration? A, is it to keep reading or doing your hobbies or playing sports? B, is it to be able to continue working? C, to maintain your independence? Or D, what might be some of your other goals? And, as we are waiting for your answers, let's talk to Eric a little bit about these kinds of issues and his experience with them.
Well, maintaining independence is certainly the thing that drove my father. He was stubborn about maintaining his independence, and it really hurt him in the end. He went out when he shouldn't have gone out and was walking in a storm and took a bad fall, and that began his decline. He really wanted to be able to continue working, and found that he couldn't. He was terrified. He was a pastor, and he was terrified that he wouldn't be able to keep delivering his sermons. He wouldn't be able to see his notes from the pulpit, and and reading was almost impossible for him. This was 20 years ago, so he had a elaborate contraption to help him focus his vision and be able to read some, and it didn't work very well. In the case of my relationship with Anne, she continues working at a much higher level than I do. This is why I don't like the term caregiver. I don't take care of her. I'm her sighted helper. She's a clinical psychologist, and she operates at a higher level than I ever did in my job.
Thank you. So the answers to the poll, while most of you answered D, you had other reasons. A significant number of you said that you wanted to be able to keep on reading and doing hobbies or playing sports. Okay, Dr. Lowe.
Yeah, I love those poll questions, and it's disheartening to hear some of the answers from those. So really, healthcare, and especially disease management, is a team sport. Right? We have family helpers, but your caregiver, your doctors, and as doctor-patient relationship goes, in our practice, we feel if you don't know more about your eyes or your eye health when you leave than when you came in, we really haven't done our job. Because the more I can educate you and your helpers, the better outcomes we're going to have. So talk to your doctor about what's going on with you. Again, to reiterate, if we catch things early, the outcomes are better. I love Dr. Brown, but my goal is to keep you from his very capable hands for as long as possible and not needing to go on to advanced macular degeneration. So talk about what your lifestyle goals are. Remember, this is affecting those of us later in life. And when you look at those of us who are getting older, I'm the tail end of the baby boom. We're all getting older and living longer, and we want to stay active. So it's important to share those with your doctor and what your outcomes, what you expect from your outcomes and what you're at risk for. And, so it's not just, can I read this chart? Can I read this 20/20? Can I, drive? It's a lot of other things, because when your vision goes down, you fall more, you mistake medication. So it really lends itself for you losing independence. And that's what we don't want. So, I'll have Dr. Brown take over what you can expect when you do have treatments.
Yeah, basically I've gone over this, but if we catch you early, you're going to get 1 to 3 injections, and then they're going to tailor your treatment to the interval you need. Most of the time, once you find that interval stays the same, whether that's 6 weeks, 7 weeks, 4 weeks, 12 weeks. You certainly want to try to not miss visits. When you are having trouble seeing and functioning, ask to see about a low vision specialist. Certainly, they can help you function to do the things that I can't do. Dr. Lowe can do a lot of it, but then there are people who specialize in magnifiers and lights and aids. So main thing is we got great treatments. We're going to have better treatments. take care of yourself and have an open conversation with your doctor.
Yes, absolutely. Absolutely. So, I wanted to just say here, managing your condition, again, it's a team sport. But the cool part about early macular degeneration is the therapies. Eating better, moving your body, taking carotenoids are no side effects, and they're just good for your general health too. So staying active, protect your eyes using sunglasses, take your medications to keep your hypertension in control and diabetes in control and all those other systemic conditions that could lend itself to advancing macular degeneration. But really the key is having that yearly routine eye exam. And then, if you are having problems, even call in sooner. So, Eric, you're such a great sighted helper for your wife. Do you want to jump in here and just talk about the managing when you do have vision loss?
One of the things that stumps me is trying to imagine what it was like for people with vision loss before there were computers and various artificial intelligence assistive things. Nowadays, do you know how hard it is to shop for, say, for example, a stove that has actual knobs on it instead of a flat pad that you have to punch the numbers on, or a thermostat that you can actually feel the right button to push, as opposed to just a soft gel pad or whatever they make them out of. Now there are all these voice-activated devices that you can install in your home that make a lot of things a lot easier. And LED bulbs are just unbelievable. We have rooms now in this house that are dazzlingly well lit. There are a lot of things that you can do, and we haven't even scratched the surface. I know people who are really expert at iPhone apps and various other kinds of computer-assisted lifestyle choices that are really phenomenal. But we've only scratched the surface.
Absolutely. Yeah, definitely light's our friend, especially when there's any decrease in vision. So great.
Let's watch another clip of Sandy talking about her advice for others.
I would have had barriers if I didn't have a husband, because I wouldn't have been able to drive to my treatments. Because you always, they dilate your eyes frequently. That would have been a barrier. I no longer drive at night. I could drive during the day, but I don't have to drive during the day because I do have a husband. Do not be afraid. And always know that there are other people just like you, more than likely in worse vision conditions than you have, because it is a condition that ultimately does get worse. If it's the advanced dry of macular degeneration, because there is no cure yet for the dry form, that will get worse. But there is the cure for the wet, and those are the anti-VEGF drugs, the injections, and to never be afraid of finding out more about your eye diseases.
We'd be remiss if we did not address a very large part of the experience of living with macular degeneration, and that's really the emotional aspect of living with it. It really extends beyond emotional. It can be psychological and spiritual also in nature. And out of our survey, we discovered that the people to whom patients with macular degeneration turn to talk about their experience, it's a variety. Obviously, a significant number of people talk to their eye care specialists, but it's great that we have Eric with us, because you can see 54% of people turn to their significant other to have these discussions, or 47% with members of their family. Sometimes it's their children or friends. But interestingly, very few people turn to their religious counselor or to a psychological counselor. And, those are probably other great sources of support, and you might find some unexpected answers for them. So
it's such an interesting coincidence for me that of the two profoundly vision impaired people in my life, one was a religious counselor, the other was a psychological counselor. Go figure. But my father clearly was not among the 34.8% of macular degeneration patients who talk to their children. My dad talked to me about it, about the emotional part of it, very rarely. He was so taciturn. He maybe once. I remember we were having lunch in the art museum that was across the street almost from his house. And I said to him, you know, if I were retired and living this close to the art museum, I'd come here, I think, every day. And he said, yeah, well, it would really help if you could see the exhibits. I didn't realize until he said that his vision loss was that bad. I thought he just kind of couldn't see very well, but it was more profound than that. He found it difficult, I think, to talk about it. And Anne has lived with it her whole life, or she's known that she was going blind her whole life, so she had a long time to get used to it. Her emotional and spiritual struggle is not so bad. She's an emotionally and spiritually strong person.
Well, it's really amazing how much we can learn from others who have macular degeneration. So I just want to read you a few quotes that we've received from people who are living with macular degeneration about the diagnosis. Don't feel sorry for yourself. Get informed as soon as you're diagnosed with AMD. The better informed you are, the easier the transition will be. That's obviously something we've talked about extensively today. Here's another one. If you think your vision loss has changed, it has. Don't hope it will go away, because it won't. I'm talking about the treatments. Focus on how much vision you still have, not how much you have lost. I think that's a really important point, because if it was me, I would focus on the negative. I just know it about myself. It's hard for me to focus on the more positive, but once I do, I get tremendous relief there. You cannot be rushed into getting the shot. You need to be heard. You need to have questions answered regarding the side effects. So again, that's a statement that supports what we've been talking about, finding your own voice to speak with your doctor. Okay, if you download the slides, you'll be able to read the rest of the quotes. Now, I just want to quickly, briefly mention that if you have more questions or want more information, you can always visit our foundation, which is the American Macular Degeneration Foundation at www.macular.org. We have a great cookbook. It ties right into what we've been talking about. It is kind of a unique cookbook. It's completely based on science, but also is incredibly tasty. You'll learn a lot about what you should be eating and how to prepare it as well, which is really important. Okay. Let's see. We're coming up on our last question, and it's to Dr. Lowe. Who should be screened for macular degeneration and how often?
All adults should be screened for macular degeneration. So once you hit your 40s and older, that's the higher risk age. So you should be having full scope primary care eye exams, and we will pick up any signs or symptoms, and sometimes well before you have structure changes or vision loss. And again, that's the sandbox we want to be playing in. We want to be very aggressive on preventive measures. So, that's an easy answer. Every adult should be getting their eyes examined.
Well, it's really been an honor and a pleasure speaking with all of you today. I want to thank Dr. Brown, Dr. Lowe, Eric for joining us today, and also thanks goes out to Sandy for providing us with a very informative discussion. And thank you to our audience, because in joining us and asking these questions, you sort of helped us all learn more. The American Macular Degeneration Foundation is pleased to be a partner on this program, and I want to once more emphasize that the support for the program came from Novartis Pharmaceuticals. After the program's over now, I just want you to remember to complete a few more questions at the end of the program to help reinforce some of the topics that were covered today. And as a reminder, you can see the event resources section of the player, which is located under the video box, to download today's slides if you want to go back to them and refer to them. Further, if you want to repeat the program, if you want to tell other people about the program, it's going to be available on demand. And you'll be able to get further instructions from that by visiting our website soon. My name is Matthew Levine. Thank you for joining us today.